All right, let's dive right into this explainer. Today, we're putting on our clinical detective hats because we are unpacking the exact guidelines for evaluating, diagnosing, and managing thyroid swellings. Whether you're seeing a patient in the clinic or reviewing case studies, we're going to break down exactly how to demonstrate and document the correct clinical examination of these swellings, how to logically tackle the differential diagnosis, and finally, how to execute the precise management plan.
So you've got a patient in front of you with a new neck lump. How do you evaluate it? We can't just guess, right? We have to follow a strict deductive framework. It starts with your hands during the clinical examination, moves through target investigations to identify the real culprit, and ends with executing the absolute correct management.
Here is our roadmap for today. We'll cover 1. Assessing thyroid swellings. 2. Key diagnostic investigations. 3. Differential diagnosis. 4. Managing benign conditions. And 5. Managing thyroid cancers. Let's get into it.
Section 1. Assessing thyroid swellings. Let's start with the clinical evaluation. Because a normal thyroid gland is pretty much impalpable, nailing down our terminology during the clinical exam is absolutely crucial. Any swelling has to be categorized accurately. A generalized enlargement, that's a goiter. Now, if you feel a discrete nodule in just one lobe with a normal gland everywhere else, that's an isolated swelling. But if you feel the discrete swelling and notice abnormalities elsewhere in the gland, you've got to document that as a dominant swelling.
Now, while your hands are on the patient, you are actively hunting for red flags. Texture alone is a bit tricky, sure, since tense cysts can sometimes feel hard. But a genuinely rock-hard, irregular swelling that feels completely fixed to the surrounding structures, that's a massive red flag. And if you combine that fixation with hoarseness, which points to a recurrent laryngeal nerve palsy, or if you palpate enlarged cervical lymph nodes, well, that clinical picture is almost diagnostic of malignant disease.
Section 2. Key diagnostic investigations. It's time to look beneath the surface. Once we've done our physical exam, our absolute workhorse investigation is the ultrasound. It is a total game changer. It allows us to accurately assess the gland, check the regional lymphatics, and crucially guide our needles for a biopsy with pinpoint precision.
And we aren't just measuring size here. By analyzing specific physical characteristics on the ultrasound, like the nodule's number, its shape, the margins, internal vascularity, and especially the presence of microcalcifications, we can decide right then and there if a nodule is reassuring or if its malignancy risk means we need to move to the next definitive diagnostic step.
That next step is fine needle aspiration cytology, or FNAC. It's the go-to investigation for discrete swellings. You absolutely have to memorize this Thy1 to Thy5 classification system because it essentially dictates all future management. For example, getting a Thy2 is reassuringly non-neoplastic. But if you see a Thy3 follicular lesion or anything higher, that pushes us directly towards surgical intervention.
Section 3. Differential diagnosis of swellings. Deducing the culprit. So, here is a pretty sobering fact for your differential diagnosis. Roughly 15% of clinically isolated thyroid swellings actually turn out to be malignant. That is a substantial chunk of patients, and it's a number we simply can't ignore when doing our evaluations. To help mentally model this risk of malignancy, we lean on clinical heuristics like the rule of 12. Think of it this way. Isolated swellings are riskier than dominant ones, solid is much riskier than cystic, and men are at a higher risk than women. So, putting that together, a solid, isolated swelling in a male patient, that's a prime candidate for carcinoma. Furthermore, if you ever see a discrete swelling in a teenager of either sex, keep your guard up. They are at exceptional risk. Now, you're probably wondering, what about isotope scanning? Well, for distinguishing benign from malignant lesions, it's mostly obsolete these days. Mostly because 80% of cold swellings are benign anyway. However, it remains absolutely invaluable for localizing overactivity in a patient whose nodularity coexists with toxicity. If you see a hot swelling, that almost always points us to a benign toxic adenoma.
Section 4. Managing benign conditions. Let's map out our management pathways.
Check this out. The physical impact of even a benign condition can be literally breathtaking for the patient. You can see how a simple benign multinodular goiter has grown straight down retrosternally, completely displacing the trachea. This causes severe pressure symptoms. So even though it's technically benign, it absolutely demands surgical intervention.
So, when exactly do we take the patient to the OR? Even if a swelling is presumed benign, there are hard indications that force our hand. This ranges from those compressive pressure symptoms we just talked about to a mere clinical suspicion of neoplasia based on our red flags, to a Thy3 or higher on the FNAC report.
When we do operate for benign but overactive conditions like Graves' disease, it's a massive clinical balancing act. You're constantly weighing a total thyroidectomy, which guarantees immediate control but results in 100% immediate thyroid failure and lifelong thyroxine reliance, against a subtotal procedure, which carries up to a 5% lifelong risk of recurrence. It's a really critical, nuanced conversation you have to have with the patient.
Section 5. Managing thyroid cancers. Let's wrap up with our management strategies.
Okay, first, a huge clinical warning. Yes, about 55% of cystic swellings are just harmless, benign colloid degeneration, but we have to remember that about 10 to 15% of cystic follicular swellings are actually malignant. What we are seeing here is cyst formation inside a papillary carcinoma. The big takeaway, never ever assume a cyst is entirely harmless without a really thorough evaluation.
After we've done the surgery for a confirmed cancer, the multidisciplinary team has to pull off a perfect balancing act with the patient's medication. For our high-risk patients, we use high-dose thyroxine to suppress any dangerous remaining thyroid cells. But for low-risk patients, we back off to physiological replacement levels. Why? To avoid the very real risks of long-term heart arrhythmias and bone loss from oversuppression. Which brings us to a really fascinating modern dilemma at the absolute cutting edge of thyroid management. We now know that only about 30% of tiny, low-risk papillary cancers under 1 centimeter will actually grow. So, do we subject the patient to surgery, or do we rely on active surveillance? It's a provocative final thought on the evolving and sometimes restrained nature of modern clinical intervention. It just goes to show that sometimes the absolute best management plan is simply to watch, wait, and truly understand the disease.